चालू कर रहे हैं अतुल भाई?
Yeah, we are live.
Should I start?
Yeah, Vinay, let me start. We are live. Welcome to Ortho TV online POSI webinars. This is just a small disclaimer. We would like to thank all our faculty for sharing their knowledge and expertise with all, especially in such challenging times. We wish all our audience a healthy and safe days ahead, and we hope these webinars add value to your time. These webinars are dependent on internet speed, which might be at times unstable, so please bear with us for any issues with the internet. All the information and academics discussed in the webinar are sourced by the speakers from reliable sources. However, please use the information provided in the webinar only after confirming with standard teaching. The opinions in webinar are for academic purposes only and are not a substitute to evidence. The speakers, neither the portal is responsible for any untoward events caused due to information presented in this webinar. So I hand over the proceedings to Dr. Atul Bhaskar, who will be moderating today's session.
Greetings on behalf of POSI. Welcome to the 9th live webinar on Cavovarus foot deformity in children and adolescent surgical management principles. Our guest speaker today is Dr. Mary's Bouchard, our panelists are Dr. Thomas from Vellore and Dr. Virat Shingade from Nagpur. We also have Dr. Dhiren as well as Dr. Sandeep Patwardhan. To give a brief background of Dr. Mary's Bouchard, she did a medical degree from McGill University, completed an orthopedic residency from Toronto, and she's done 3 to 4 foot and ankle fellowships, one with Dr. Tim Daniels in Toronto, a stint in Belgium, fellowship with Win Mosca, and a limb reconstruction fellowship at the Royal Children's Hospital in Melbourne. She was staff at the Seattle Children's Hospital, University of Washington for 3 years. And then I guess she missed the cold winters of Toronto, the maple syrup and hot coffee of Tim Hortons. So she moved back to her beloved Canada. She's currently staff at the Hospital of Sick Children and an assistant professor. Over to you, Marys.
Thank you very much for the kind introduction, and definitely the maple syrup had me looking back to home. It's really a pleasure to get to speak to all of you today. I really appreciate the invitation, and I will start sharing my slides with you. All right, so today we'll go over mostly the surgical management principles around the Cavovarus foot deformity in children and adolescents. I have no disclosures, and thank you to my mentor, Vince Mosca, of whom some of his published principles and images I'll borrow for parts of this talk. So we'll start with the more boring stuff, the etiologies, assessment of the child and the foot, non-operative management, and then we'll get into the meat of surgical management, and we'll discuss cases as we go through all of the concepts. So for me, the principles of managing a Cavovarus foot really boil down to 3 important concepts. First, you need to identify the etiology, knowing if this will be a progressive deformity, unilateral, bilateral. These are key for being able to pick the right treatment for this child. Then you have to remember that no treatment is one size fits all. Your treatment has to be based on principles for the foot right in front of you, and it may be different from the left foot to the right foot. And we'll go over what are those principles, what are those questions that I ask myself to figure out the best plan for each patient. And lastly, to me, you need to treat progressive deformities early while they're flexible, while the children are younger, to prevent rigid deformities that become much more difficult to manage in older adolescents and adults. Etiology. Essentially, Cavovarus feet are very rare in children under 3. Most often it's due to a neuromuscular concern. Hereditary sensory motor conditions such as Charcot-Marie-Tooth are the most common. But you can't forget the array of other issues all along the neuroaxis from the brain down to the peripheral nerves. We do know that prognosis is worse when disease has an early onset. And so again, to my first point, it is really important to consider treating these kids when they present, even if they're younger at that time. So the history and physical have to be thorough. This is not the type of patient that you can send in the medical student to do a cursory exam and come out with all the answers. You need to know everything about the onset and progression of the deformity, if they have pain, shoe wear issues, if there's any family history. And in addition to a detailed exam of the foot and lower extremities, you really need to do a proper head to toe physical and neurologic examination. For the lower extremities, for me, this starts with a standing exam, looking at their lower extremity alignment, muscle bulk, asymmetry. Often, particularly with Charcot-Marie tooth, there's this classic stork-like appearance of very thin calves, thin legs with a high arched foot. When you have them walk, you want to take note. Do they have a drop foot? Are they recruiting their toe extensors because their dorsiflexors are weak? Are they compensating for that weakness with a high steppage gait? So using flexion of the hip and knee excessively. You want to look at their feet. Are there calluses? Is their skin baked down? And you also want to pay attention to the ankles. Is there some lateral instability there from long-standing varus? We'll go over the foot exam in more detail with my principles, but when it comes to imaging, standing AP and lateral x-rays of the feet and separately of the ankles are the baseline for me. Often a lateral of the foot, especially when there is cavus, is not a lateral of the ankle. Your tech might be setting up the beam perpendicular to the forefoot, but not perpendicular to the ankle. And so you'll get very awkward looking anatomy of the talus, calcaneus, and the tibia. So I separate those exams. If I'm also concerned about the hindfoot alignment, a Saltzman view as opposed to a Harris view is my go-to, and I'll show you examples of that in a second. And I also perform x-rays on and off the Coleman block to confirm the suppleness of the deformity. CT scans are rare for me in Cavovarus feet. I save them for those with severe deformities, ones I might suspect have degenerative changes, and those that may have a tarsal coalition. When I have the AP x-rays, I try to keep it simple. I'm looking at basically 2 points of alignment. First is the AP Meares angle, the axes between the first metatarsal and the talus. I'm not so worried about what the angle is. Typically it should be 0 between them, but whether it's 30 or 20 is not so important. But where they intersect is more important to me. And typically it's around the talonavicular joint or talar head. I also look at the divergence between the calcaneus and the talus, which is normally around 30 to 40 degrees. But in a Cavovarus foot with hindfoot varus, they'll approach parallel. On the lateral, similarly, I keep it simple with a calcaneal pitch, which I like to use to assess if there's any subtle or even less subtle equinus, and also the traditional Meares angle between the talus and the first. And again, it tends to intersect at the medial cuneiform. And again, it's not the magnitude of this deformity, but the apex of the deformity that I'm curious about. Here's an example of 2 kids who had their x-rays on the Coleman block. I find the AP and the Saltzman to be the most interesting, but you can see on the upper left, this child steps on the Coleman block and there's really minimal improvement in their Meares angle. And when the child on the right steps on the block, you have an almost overcorrection into a flat foot, which would confirm your physical exam, assuming they've corrected on the Coleman block. So on the left here are the Harris views, which are great if you have calcaneal fractures or a tarsal coalition of the subtalar joint, but they don't show you much tibia and they don't tell you much about hindfoot alignment. So I prefer the Saltzman view. And here you can see much more tibia, and you can even have the child step on a Coleman block during a Saltzman view, and you can see quite a dramatic difference in the calcaneal alignment relative to the shaft of the tibia when the child is on a Coleman block. We can't forget that the feet are attached to a child who has a body proximal to that. So particularly in conditions like Charcot-Marie tooth, silent hip dysplasia is not uncommon. So an AP pelvis is mandatory for me in any child that I suspect may have Charcot-Marie tooth. If on my exam I notice any hint of scoliosis, I do not hesitate to get an X-ray series of the spine. If I'm part of workup, I don't have a known etiology, then I might be coordinating with my neurologists or neurosurgeons to get brain and spine MRIs, nerve conduction studies, and if needed, extremity MRIs for peripheral lesions. Non-operative management to me has very little role in Cavovarus foot, Essentially, it's trying to manage symptoms while we wait for surgery. Almost all of these deformities are operative. That non-operative management might include some physiotherapy for strengthening or muscle balance, orthotics, bracing, casting, and Botox in the case of certain patients with cerebral palsy. There's really only one study with positive findings of using non-operative management, which was a series out of France that used turnbuckling and serial casting. To me, the conclusions are basically that they were able to defer surgery, but most of them still required some surgical treatment at a point in adolescence. So surgical indications are pain, shoe wear difficulty, and progressive deformity, which is pretty much all patients with Cavovarus feet. The goals are mobile, plantigrade, pain-free feet, and to prevent rigid deformities from developing. The surgical management principles that I adhere to are the ones clearly described by Dr. Vince Mosca. So these are essentially, when I'm operating, soft tissue procedures before the bony procedures. Soft tissue procedures are typically all that's required for flexible deformities, but you need to consider adding bony procedures with rigid deformities. Try to perform your osteotomy as close to or at the apex of the deformity. Tendon transfers should be tensioned after the residual deformity correction. And you might want to consider staging your procedures when the deformities are rigid, and you want to be as joint and physial sparing as possible in children. So this is how I make my decisions. I ask myself 5 key questions, or I ask myself to look at 5 key things on my physical exam. And as I go through each of these, I develop my surgical algorithm for each patient. So we'll go through them one at a time. So first, is there forefoot pronation or midfoot cavus? This results from the excessive overpull of the tibialis anterior relative to the peroneus brevis, causing a flexion through the first ray. And it's worsened by the weak intrinsics, particularly in CMT, where you have a shortening of the plantar fascia that continues further elevation of the arch. So on exam, I ask myself, can I manually flatten out this arch? Can I push up the first ray and get a flat arch? If the answer is yes, then typically only a soft tissue release is needed. And that would be the superficial plantar medial release, which includes the plantar fascia, and the abductor hallucis, which is removed from the proximal portion, not the distal portion. If I cannot flatten out the arch, then I suspect I will also need a midfoot osteotomy in addition to my superficial plantar medial release. We'll go over details of the midfoot osteotomy a little bit later. The second thing I look at is the hindfoot varus. I want to know, is this forefoot driven or hindfoot driven? And that's where your Coleman block test comes into play. If you have significant cavus, the foot wants to maintain a tripod between the first metatarsal, the fifth metatarsal head, and the heel. So if you have excessive plantar flexion through the first ray, the only way for the foot to keep all 3 points on the ground is to roll towards the outside border of the foot, pushing the hindfoot into varus, as you can see in those top 2 images. So the Coleman block test allows you to have that first ray be extra plantar flexed while keeping the lateral border well balanced. I prefer to do the modified version of the Coleman block test as described by Dr. Mosca. So only the 4th and 5th metatarsal heads are on the block, or metatarsals are on the block, and the heel is floating. If I have full correction of the hindfoot varus into valgus, I consider that then to be a forefoot driven cavus. If the hindfoot only improves but is still in varus, or only goes to neutral, to me that is not a full correction. And at this point, you now have a rigid hindfoot varus. That typically comes from longstanding overpull of tibialis posterior relative to tibialis anterior, which pushes that hindfoot into varus, and then the tendo-Achilles acts as a secondary inverter, worsening the deformity. So if I have a Coleman block test where I correct to valgus, then I typically only need midfoot cavus correction. So that's a deep plantar medial release now. So your plantar fascia, abductor, a tibialis posterior lengthening, recession you might want to consider in a spastic etiology, and a talonavicular joint capsulotomy, and add a midfoot osteotomy if needed. If the hindfoot, however, is fixed in varus, I'm going to need to do those soft tissue releases, and in addition, an osteotomy through the calcaneus. Again, when you're looking at that hindfoot varus, you want to check for ankle instability. It's rare in children, but certainly in adults, if you have lateral instability, you may also need to consider a reconstruction or a supramalleolar osteotomy of the distal tibia. Third, I look at whether there is dynamic supination. So in a dynamic state, this occurs just through swing phase, or as you can see when seated here in an active dorsiflexion. The left foot, you have your first toe elevated more than the pinky toe with no real eversion. And on the right foot, a nice balanced forefoot that's in an up and out position. The goal here is to restore your muscle balance of the tibialis anterior, which is stronger than the everters. When you have a fixed supination, that means it's occurring in stance and all the way through push-off. And in this case, it's an imbalance between tibialis posterior and tibialis anterior. And the goal is going to be to really weaken that tibialis posterior or even redirect it to another place in the foot. So options for treating supination include, in the dynamic case, a tib post lengthening or weakening of some kind, combined with a split or full tibant transfer and possible longus to brevis perineal transfer. In the case of a fixed supination, you might need to consider a split tib post or a total tib post transfer, and any other osteotomies you might need for correcting deformity. Next, I ask myself if there's equinus, and this can often be tricky. Equinus can certainly happen in CMT, but not in the classic presentation. However, we often find people wanting to do strayers or lengthen the Achilles. And I think this comes from what is actually just a misevaluation, if you will, of the deformity clinically. A severe cavus will often make the foot look like the toes are much further plantar than the heel, which at first glance might look like equinus. But if you cover the forefoot and just look at the alignment of the heel relative to the tibial shaft, you actually notice it's often at least 90 degrees or even dorsiflexed. So it's really important to force yourself to consider whether there is equinus or just severe cavus, do a proper silver skull test, and from there make your decision. If there's no equinus, then no procedure is needed to lengthen the heel cord. If there's a positive silver skull test, you might consider a strayer or gastroc recession. If the equinus is mild, a mini open tendo-Achilles lengthening may be sufficient. And if the equinus is severe, you might need to consider an open tendo-Achilles lengthening. Lastly, I look at the toes. In children, thankfully, these are typically just flexion deformities of the toes, and they're often flexible. To test flexibility of a flexion contracture through the IP joints, you can do the push-up test by sticking your thumb under the metatarsal head. By elevating that ray, often a flexible deformity will show a full extension of the toe. If it remains flexed, however, in that case, you might need to do more than just soft tissue procedures to get the toes out to length, such as resection, arthroplasty, or fusion. In the cases of claw toes, again, you might be able to get away with tendon transfers in the flexible deformity, but you might have to consider fusions in the rigid deformities. We've pretty much discussed most of the tendon transfers that are incorporated through different reconstructive options for Cavovarus feet. But to summarize, for the forefoot pronation, you might want to do longus to brevis perineal transfers. For dynamic supinations, tibialis anterior transfers. For fixed supination, tib post to dorsum. And for me, these are more in the presence of severe weakness, such as a drop foot or absence of everters in older children, and in those that have a risk of becoming severe deformities or significant progression. Hibs and modified Jones transfers can be considered for your claw toes. So now to the bony parts. Although osteotomies in the forefoot are frequently described, typically through the first metatarsal, but also transmetatarsal osteotomies, I tend to stay away from these in children. For the first reason being that there's usually a physis at the base of the first metatarsal osteotomy, right where you'd want to do your cut. But most importantly, because as I mentioned before, the apex of the deformity is typically at the medial cuneiform, not the first metatarsal. And so I would rather perform my osteotomy at the location of deformity. Midfoot osteotomies for me in the mild to moderate deformity is typically sufficient at the medial cuneiform, again, aiming for that apex of the deformity. And I usually do an opening wedge type osteotomy. Dr. Mosca and I recently published a paper that confirmed his suspicion, which is that if you look at the anatomy of the cuneiforms, the medial cuneiform has soft tissue tethers, distal, proximal, and lateral. So if you're going to do an opening wedge osteotomy, even if your intent is purely to correct the sagittal plane, such as plantar opening or dorsal opening, you almost always get some slight medial opening as well. Whereas if you're trying to do a purely closing wedge in the sagittal plane from a medial or even dorsal medial approach, you'll end up getting a little bit of a medial closing because of the approach that you're using. So we tend to take a little bit more bone from the medial side of the cuneiform inadvertently, but also again, that soft tissue tether on the lateral side. So in a Cavovarus foot where we know we have some forefoot adduction in addition to cavus, it's always, I think, a little more desirable to have a slight medial opening wedge moment than to have a medial closing moment. So for that reason, I tend to pick a plantar medial opening wedge osteotomy to correct both deformities at the same time. In order to get the best mobility, I aim the osteotomy from the midpoint of the cuneiform, usually just behind the tibialis anterior, towards the second TNT joint, and then use a lamina spreader or Hintermann distractor to open up the osteotomy and place a triangular shaped wedge of graft. You can use autograft, allograft, all work well. The other advantage to this is it tends to be press fit, so you don't usually need to use any internal fixation or even percutaneous wires to hold the osteotomy. In the severe deformities, you may include multiple cuneiforms or even the cuboid as well. This is just a video to prove the point. This was a child with skew foot deformity with severe adductus, but you can see when you aim that osteotomy right at the second TMT joint, you really have a lot of freedom of movement there and can correct quite significant deformities, even with just a single osteotomy, an osteotomy of a single cuneiform. So let's apply these principles to a couple cases as we go. So this was an 8-year-old girl who presented with a unilateral Cavovarus foot. She had no family history, no medical or surgical history. She was worked up thoroughly. MRIs of the brain and spine were normal. EMG did show some sciatic nerve dysfunction, but even an extremity MRI showed no abnormality. On exam, she had rigid cavus with forefoot pronation. She had no supination, no drop foot, flexible toe contractures. Her hind foot did correct on a Coleman block, and she did have a subtle silver scold exam, which you can see on the x-rays. We have an apex lateral Meares angle, some parallelism of the hind foot. Apex of the Meares angle on the lateral is right at the navicular cuneiform joint. And then if the calcaneal pitch is on the low side of normal, and the talocalcaneal angle is also on the low side of normal. So how did I decide what to do? So we'll go through this one really step by step. So we have a rigid midfoot deformity. So she's going to need not just soft tissue, but also bony correction for her midfoot cavus. So that'll include the superficial plantar medial release of the plantar fascia and the abductor, the midfoot osteotomy, plantar medial opening wedge, and a longus to brevis transfer. She has a hindfoot varus, but it's correctable. So we'll need to extend our plantar medial release to the deep structures of the tibialis posterior and the catalonavicular joint, but we don't need to do a calcaneal slide. She had no supination and no foot drop, so we didn't need any additional tendon transfers. Her toe flexors were, toe flexion contractures were flexible, so percutaneous tenotomies of the FHL and FDL distally were sufficient, and she had a positive silver scold, so I added a strayer. Now, to talk about staging. In the midfoot deformities that are rigid, I tend to like to do them surgeries in 2 stages, separated by 2 to 3 weeks apart. This is a bit like clubfoot correction. If I were to release all of my plantar medial structures and try to go on to do a plantar medial opening wedge osteotomy, my rate limiting structure is now the skin plantar medially, and I might not get a full correction. So I prefer to do my soft tissue releases, including the toe flexor tenotomies, and then let the kids walk around on a short leg cast for a couple of weeks, which stretches out the skin. So when I go back later, I can now get more deformity correction through my medial cuneiform osteotomy, and then I save my tendon transfers to the second stage. If I think I'm going to need to lengthen anything in the triceps suri complex, I also do that at the second stage for the same reasons that we don't do the Achilles tenotomy early in clubfoot corrections, because we want to keep that tension on the calcaneus to better stretch out the plantar aspect of the foot. If we release it right away, we have no posterior tether and we don't get as nice a correction or stretch through that midfoot. Another child, 16 years old, presenting with bilateral metatarsalgia and high arch feet. After our exam and our history, we presume Charcot-Marie tooth. He has a reflexic lower extremities. His EMGs were normal, which is typical in early Charcot-Marie tooth. His brain and spine MRIs were also normal. He had slightly asymmetric deformities, and he had mild perineal weakness on testing for manual eversion. His midfoot deformities on the lateral are right at the medial cuneiform as expected. Not much improvement when standing on a Coleman block test. When we look on the AP plane, we see again the left foot is not quite so bad with relatively preserved Meary's angle, but an apex lateral on the right. And this corrects perfectly when he stands on a Coleman block. So what should we do for him? Essentially, we have rigid midfoot deformities and correctable hindfoot varus. So similar to our last child, he's going to have a two-stage reconstruction. On the left, because he didn't have any hindfoot varus at all, he doesn't require a deep release, just superficial. And then on the second stage, we do our medial cuneiform osteotomies and our longus to brevis transfers. Unfortunately, I only had one X-ray that managed to save post-operatively, but at a year and a half out, he's still happy, pain-free with no progression of disease. So what about the hindfoot? The workhorse osteotomy is the lateral translation posterior calcaneal osteotomy. This can be done open or now, as is more popular, minimally invasively. The adult literature reports that there are less neurologic injuries, skin injuries, good wound healing, less pain, less swelling, and quicker return to function. Studies in children have not been looked at, particularly in the hindfoot, but I've certainly started to use this technique in my flat foot corrections, especially if there's double osteotomies, calcaneal lengthening, and a slide, and in other osteotomies when associated with a big reconstruction, like a triple fusion that also needs a calc slide, or in these cases, double osteotomies for Cavovarus reconstruction. One of the important principles to think about is the direction and location of your cut. Herzenberg reported that the highest risk of neurovascular injury was if you went right in the middle third of the tuberosity. And Vince Mosca also describes doing it in the plane of the metatarsal head cascade in order to prevent lengthening or shortening of the foot inadvertently. So it's not just about putting your saw blade perpendicular to the lateral wall of the calcaneus, but doing it in the plane of the metatarsal heads, which he tends to identify by putting a wire in the plantar posterior aspect in the plane of the metatarsal heads, and then keeping the saw blade parallel to this. I do find when I go MIS that it's difficult to place that wire, as you typically have the foot in a lateral decubitus position, and so the wire tends to want to penetrate the drapes, so you do need to be careful. The images below come from an MIS osteotomy, where you can see as we start the burr cuts, you can make out the subtle shadow. I use a Williger type tool to help with the translation through the keyhole incision, and then place screws for fixation. Lastly, in the hindfoot, you need to consider the need for supramalleolar osteotomies, whether to add valgus or correct rotation. So now let's go through a case. We have a 17-year-old female, believe it or not, confirmed Marfan syndrome with obesity and a unilateral Cavovarus foot. So not your typical Marfan's presentation in the slightest. So as a child, her father was told this was a clubfoot, but it never had any treatment or required treatment. Clearly a little bit curious about the etiology, obtained an MRI, which showed a distal sacral arachnoid cyst, which neurosurgery thought was asymptomatic and didn't need treatment. So as you can see in the upper right corner, she doesn't correct fully on a Coleman block test. She had a rigid midfoot cavus, but good everter function. So she's not, your typical CMT. These were her x-rays, again, with a midfoot deformity. So for her, again, my two-stage reconstruction, first soft tissues, including the deep release because she had hindfoot varus, and then the second stage, including a plantar medial opening wedge osteotomy and a lateral calcaneal slide. I opted to go MIS because of her obesity, her difficulty with potentially being in a cast for a longer period, and I wanted to keep soft tissue risk down. So she ended up doing very well with her correction and MIS procedure. So what do I do post-op? If I do soft tissue only procedures, I tend to put them in a short leg cast for 4 to 6 weeks and allow them to walk. If I've added osteotomies or tendon transfers, it's usually 6 weeks in a non-weight bearing cast. I don't brace everybody. I don't have evidence for all of this, but typically those with known severely progressive or rapidly progressive conditions or severe deformities, I tend to make an AFO for. This will be hinged. If there's equinus, I will add a 90-degree plantar stop and nighttime dorsiflexion straps. And for any equinus that is not progressive, I will tend to use it for at least 6 months at night. I do recommend physical therapy, at least for gait training, but especially in those with excessive weakness or who had tendon transfers of the tibialis posterior. And again, it's really important to maintain follow-up with these children right in and through adulthood. What are our other options? So gradual deformity correction in the pure Cavovarus foot, I find not to be a particularly frequent tool of mine, but it definitely has its uses. I use it in the very severe deformities that are rigid, that would not be corrected fully with acute osteotomies, and those with more complex deformities, such as an equino-Cavovarus foot. If the children are younger, soft tissue distraction may be all you need. You might need to add osteotomies. If they're older, they can be V or U-shaped or single plane. You have to remember that X-fixes are X-fixes and they have complications whether you're doing a lengthening for a congenital deformity or just a foot correction, and stiffness and recurrence are still common. This was a child, albeit with a residual clubfoot deformity, but the majority of his problems were from the cavus. This is a prime example of where if you hide his forefoot, you can see actually the hindfoot's not in that much equinus. He had had multiple surgeries and was quite rigid. So with that foot already being significantly smaller than the other, and with the deformity being severe, I didn't think he was an optimal candidate for a wedge resection and wanted to try and preserve that length as well as correct deformity. I tend to shy away from two major bony deformity corrections at the same time in a frame. So ultimately, my plan for him was a midfoot osteotomy that we would use to correct his cavus gradually, an acute lateral calcaneal slide, which we did again, MIS, knowing that we were going to have wires everywhere and wanted to prevent a big incision, and an acute plantar fascia release. Within about 4 weeks, we were able to get full correction of his cavus. This was about a week prior to end of correction, but you can appreciate an improvement of that cavus. And then about 6 months later, we'll plan for a second stage acute correction for his equinus through a supramalleolar osteotomy. What about arthrodesis? Again, for pure Cavovarus, I tend to try and stay away from that as much as possible. But in multiplanar deformities, if there are degenerative changes, then certainly it's a tool to consider. If there's ankle varus with instability and degenerative changes, ankle fusions may be necessary, but this is, I find, typically in the adults. You want to try and delay as long as possible till skeletal maturity. If you are going to fuse, you have to not forget your principles and include all the soft tissue releases, tendon transfers, and adjunct osteotomies that you would otherwise use to prevent recurrence, especially in a neuromuscular foot. And now we also have to think about the future. We know adjacent joint arthritis occurs. We know that some of these ankles from sustained varus alignment will get OA. And so you might need to consider if they're candidates in the future for total ankles, and discuss with an adult colleague who does foot and ankle sooner. And certainly if you do an ankle fusion in a young patient, to perform it in a way that it could be converted to a total ankle down the road. Outcomes for triple arthrodesis and CMT are reasonably guarded, though patients seem somewhat satisfied despite the development of adjacent joint disease. And we know that they tend to do better in non-progressive conditions and if sensory function is preserved. Salvage midfoot procedures are less commonly performed now, especially again, as mentioned, because they cause rigid joints and they shorten the foot, but they're definitely still an option. One paper by Mubarak and Demeglio looked at excising the navicular with a dorsolateral cuboid closing wedge in a small series with good results. Recently, there was publication on guided growth of the base of the first metatarsal to correct cavus. I love the idea of being innovative, but I think unfortunately, in most of our practices, we're seeing patients with cavus present more in adolescence, and you would need to start this type of guided growth, in my opinion, around the ages of 8, 9, or maybe 10 at the latest in order to get enough correction, but it's certainly something to think about. So with all this talk of progressive deformities and needing to get to these feet early, is cavus correction a surgical emergency? Do we need to operate on it the second we see it? Well, I don't think so, but there are a few subsets of patients that I would certainly prioritize in my surgical wait list. Those where we have rapidly progressive deformities, and that's why it's really important to know the etiology. In the younger children with severe deformities, and in those that are still flexible or are starting to get rigid, I might want to go right away. So this is a child, for example, who is 16. He has a clear family history of CMT. He's gene confirmed type 1A. He's been followed by neurology for the last 5 years, who said, your feet aren't so bad, don't worry about it. But he's actually one that I would like to get to right away. He still corrects easily on a Coleman block. His deformity's on the milder side. And right now I could probably get away with treating him with just a plantar medial release, superficial plantar medial release, and midfoot osteotomy and a tendon transfer. But if we waited till he started to have symptoms or his deformities got worse, we'd be looking at multiple osteotomies and more extensive soft tissue releases and possibly not a full correction. Lastly, again, don't forget to take x-rays of the pelvis. As you can see, this was an otherwise healthy guy who actually has acetabular dysplasia. And so he is on my wait list and also on the wait list of a hip preservation specialist. This, on the other hand, was a girl who presented to me at 11 with a rare type of CMT, type 1F, mostly autosomal dominant, different gene. Onset is early, mostly affects lower extremities, but also invariably affects the upper extremities. And she's a girl who I wish I could have seen years prior and operated on years prior. These are her standing x-rays. This is the absolute best that she can do, and she's already 11. So my options for her to get her a nice supple foot at this point are essentially zero. I can just hope to make her feet closer to plantigrade, but she is one that needs no question two-stage reconstruction with osteotomies of the cuneiform, the calcaneus. I can't tell you that I'm overly happy with the amount of correction we got, but she was already so tight when I met her. She had such profound weakness as well, which is really important to note because rehabilitation in these kids is really challenging. It took her many months till she could walk without an aid because the extra time in cast certainly don't help. And she's the type of patient that I would brace through growth, knowing how severe and progressive her deformities are. Lastly, just another plug for getting to things early. This was an 11-year-old girl with Ewing sarcoma who had a resection and chemo with a progressive rigid equino-cavovarus. Given all of her incisions and chemo, wearing an AFO was not something that was impressed upon them until too late. So for her, with absolutely no dorsiflexion or everters, our approach is a little bit different. She has a length discrepancy, but we're okay with that given her foot drop. So she is someone that I tried serial casting before to try and increase the suppleness of her skin, which she couldn't tolerate. So we got about 3 casts in. I opted to do her deformity correction in 1 stage instead of 2 because I didn't think her skin would tolerate excessive time in cast. So we did a deep plantar medial release, a tibialis posterior transfer to the cuneiform, vulpius lengthening for the equinus that resulted from not wearing an AFO, a medial opening wedge osteotomy. She ended up actually having a beautiful correction of her hind foot with the soft tissue releases, so I didn't do a calcaneal slide. And then I actually did a bit more serial casting afterwards for her equinus, including one under GA. And although she's doing well from her foot perspective, this poor girl has recurrence now of her Ewing's, but she's hopefully not so AFO dependent with a plantigrade foot now. So thank you so much for your attention. Certainly feel free to reach out to me by email if you have any questions afterwards.
Thank you very much for that very elaborate and very comprehensive treatment plan for the Cavovarus foot. We've got a few questions from our POSI members, and I'll just go through it one by one before we show one or two of our own cases. So the first question is from Dr. Rajiv. He wants to know, can you explain the peroneus longus to peroneus brevis transfer? How do you do it, and what would be the right indication for it?
Yeah, so the longus to brevis transfer, I have to admit, if I think really hard and long about it, I don't know that it necessarily makes perfect sense all the time. We know that CMT predominantly affects the perineal nerve, so theoretically it should be affecting peroneus longus and brevis equally. So why transfer if both the muscles are weak? I still do it for the reason that I would prefer to harness what strength is left all to the lateral side of the foot, rather than letting some of it still pull on the first ray. So even though both might be weak, I'd still rather put all of that weak strength to the right location. So that's why I still do it. So I do it in the presence of a forefoot pronation, a first ray pronation, where I want to take away that deforming force of the peroneus longus, and I already have weak everters. So if I am doing a calcaneal lengthening osteotomy that's open, I will do the longus to brevis transfer through the same incision for the approach of the calcaneal osteotomy. Otherwise, I do a longitudinal incision more or less over the cuboid and CC joint, where I'm a little bit further distal towards the insertion of the peroneus brevis. I do about a 1-inch incision, protect the sural nerve, identify both of the tendons, taking them out of their sheath. I pull on them, make sure I'm really comfortable that I know which one is which. And then I'll do a tenotomy of the longus as far as I see it. I don't go all the way under the plantar side of the foot. I don't think you need the whole length. And then I'll do a essentially like a mini pulver taft, and I'll make a little hole into the brevis and do a side-to-side sutures.
Right, thank you. I think there's Thomas, do you want to ask a question?
Yeah. Thanks, Maurice. That was an excellent overview. Just that we don't see that many Charcot-Marie tooth in our part of the world. I know you see a lot of neurological deteriorating feet there. So you talked about lateral ankle instability. How often do you see that in Cavovarus foot, and how often did you have to go and repair the like do a Crispin Snook or do a lateral ligament augmentation?
So in children, I've never had to do it. But the reason I bring it up is in adults, when I was doing my adult training, I couldn't believe how many adult patients we saw with residual deformity from Charcot-Marie tooth that had terrible ankle OA and longstanding varus that just had no ankle stability laterally anymore. So if they thankfully didn't have enough OA that we didn't need to fuse them, then, and we were considering a supramalleolar, then we almost always did a lateral reconstruction. But you're right, in children, very rarely, but I think it's still smart to keep it in mind when you evaluate the patients. The other plug for that was interesting. And when I did my adult foot and ankle training in Toronto, where we have a lot of CMT, we had a lot of adults with like rigid, severe residual deformities, but there wasn't a huge push at the time to treat Cavovarus feet in children. If it was kind of mild, you just left it. And then 20, 30 years later, they show up to, the adult hospital and they have horrible feet. Whereas when I went to Seattle, I was, working with Vince and then working on my own, and I was treating tons of kids with Charcot-Marie tooth and Cavovarus feet. But when I spoke to my adult colleagues, they were like, no, we actually don't see very much. We rarely do the adult CMT foot. And it really drove home for me the importance of getting to these deformities early. So you're not at that point where you're doing lateral ankle ligament reconstructions for varus and SMOs or fusions in all of these patients who really don't do that great with an ankle fusion or a triple fusion. So it was just another sort of anecdote that was enough evidence for me to say, yeah, get to these feet when you see them.
I think that's the advantage of working in a children's hospital, where you can get good long-term longitudinal follow-up with children, and you can really see the rate the way deformity progresses and secondary problems as well. One more question, Dr. Tushar is asking, what is the risk of relapse in CMT after a soft tissue surgery? How many relapses do you see, and then how would you tackle it?
Yeah, as far as I know, and I actually went through the literature again recently, nobody's really quantified relapse. There's one recent study, I think 2018, that looked at a follow-up of soft tissue releases and osteotomies for CMT Cavovarus reconstructions in children. I think the mean age was somewhere around 14 years at time of surgery, but the mean follow-up was only, or the range of follow-up was only about 6 to 32 months, so really short. That said, they didn't report relapse. They said satisfaction rates were around 90%. So short term, it seems okay. But I would say that from my experience so far, what recurs early is toe flexion contractures. However, most patients don't seem to care that much about those. So it's not causing need for another surgery, even though there's a recurrence of the deformity. And the second is progression of the hindfoot varus. So I would say that going back a second time, somewhere in the 2 to 5 year neighborhood, to add a lateral calcaneal osteotomy, I probably saw Vince do that 3 or 4 times, and I've done it once. So between 2 people in a span of 7 or 8 years, maybe 5 or 6 cases. So not that often, but what happens to them down the road in adulthood, I still don't know, but I'm working on getting that data. I'm partnering with an adult colleague in the city, and we're doing longitudinal follow-up with PROs of this patient population so we can really get a better sense, because right now we don't know.
There's a question from Dr. Rujuta Mehta. She's asking, how do you approach a neurogenic Cavovarus foot, which has got ulcers, trophic ulcers, non-healing ulcers on the ball of the great toe? Because we still see a fair amount of biomegacele population in our kind of setup.
Yeah. So I think that type of foot and residual club foot kind of fall in that category too. So I think there's a couple of things to consider. Even though theoretically, we easily think of pre-op serial casting in a child with club feet, but we don't tend to think about it as frequently in a kid with, post-traumatic perineal nerve injury who gets a Cavovarus foot, or sometimes spina bifida. So the first step for me would be serial casting to see how much you can actually improve with a total contact casting approach to try and minimize injury to the soft tissues. If they're really intolerant of casting and you can't get anywhere, I think the approach we use, and I do have a couple cases of it, and I think some of my panelists do as well, but I also like the approach of going to the OR for an initial quick soft tissue release of the really offensive structures. So tibialis posterior, tendo Achilles, plantar fascia, maybe even talonavicular joint if you need to, do an acute release. That allows you to unlock that subtalar joint, and then you start serial casting after those soft tissue releases that you do as many open as you can, and then serial cast, serial cast, serial cast, and then you can finish up if you need to with a second stage surgery for some corrective osteotomies. So I've had luck in kids with that. I've also, depending on the social situation, if that kind of opportunity for serial casting is not available, then sometimes I think you're pushed to shove and you have to do something like a Lambrinuti triple fusion to just get that foot plantigrade and stop the soft tissue injuries.
Right. Okay. So we'll take the case. Thomas, you want to ask a question?
Yeah. Maurice, I noticed in all your osteotomies in the medial side, you don't go on to the lateral side to the cuboid and do a decancellation or shortening of the lateral column. You only do the medial cuneiform and you do a calcaneal slide, a Steinler and a TL. Why isn't that you don't go to the lateral side and do a cuboid shortening or a decancellation?
I do in things like clubfoot, definitely, where you have an excessively long lateral column. But I find most just pure Cavovarus, that the curvature to the lateral border is really not that excessive. The lateral column's not that long, so you don't need to. But certainly, I keep that in the back of my head if I needed to. You're right, I didn't put it on the slides because I don't tend to in the pure Cavovarus foot. But in clubfoot, I think you absolutely need to keep in mind how you might shorten the lateral column, whether that's cuboid decancellation, a Licht-Blau resection of the distal calcaneus, or a CC fusion. I think that's very important. Yeah.
So we'll just go to some of our cases, and I think I'll just share the screen. Go back to one slide. So essentially, I think the spectrum in India is far different than what we see in Toronto. I rarely saw relapse clubfoot of severity. So in India, you get somebody coming antenatally with a scan, or you will get somebody like this and everything in between. The risk of, I think, the incidence of CMT is very low in this part of the world. So I'll take this first case, which is Thomas's case. So this is a 10-year-old boy with the right-sided Cavovarus deformity. Thomas, would you like to go ahead with this case? I'll just show the X-ray.
Yeah. So this child was an interesting case. He came from Bangladesh, and he had head injury at the age of 9 months, and then developed weakness progressively of the right foot. He almost presented like a right spastic hemiplegic with a very rigid Cavovarus on the right side. But his milestones are normal, and he only had weakness of the right lower limb and a very rigid equino-Cavovarus foot, which never corrected. And on the Coleman block, it was fairly rigid. And it was because he's been walking on that for a long time, the deformity had become fixed. Any thoughts on that, Maurice? How will you? You can see the angle, the Neary's angle and the metallo-calcaneal angle drawn. Fairly rigid, 11, 12 years old boy walking for a long time on the right foot with the callosity on the right lateral aspect.
Yep. So for me, assuming that, neurologically he seems to have normal sensation and can at least flex toes and extend toes, then to me, this is that sort of 3, if you will, staged approach of, again, assuming that this child can come for serial casting, but I would do an initial first surgery where I would release, do my deep plantar medial release, get rid of the plantar fascia, the abductor, tib post, lengthen that excessively, and then talonavicular joint capsulotomy and tenotomy of the Achilles. I would probably just tenotomize it at, he's 10, so maybe I'd lengthen, but, and then I would start serial casting and see what
11, 12, yeah, around 11, 12 years.
Yeah, so I would lengthen then, as long as he's not a diagnosis of arthrogryposis, then I would just whack the tendons. But I would start with soft tissue releases, serial cast as much as I can, and then finish off with surgery. And depending on how much correction you get, I think you can cast for a very long time, but you may hit a wall where you stop getting improvement or skin, or but then you could finish up with either midfoot osteotomy, calcaneal slide, maybe even he's 11, so depending on what your tibial deformity is, I would definitely get some ankle x-rays at when he's a little improved and see if you could do any guided growth or if you need a supramalleolar.
Yeah, so like Mary said, that was the AP.
Oops.
No, you'll have to go. No, this is the other one. Yeah.
Yeah, sorry, yeah. So what was done, Thomas? What did you do?
So we did, like Marie said, we started off with a soft tissue release, a Steinler, a TAL. Then, because of the foot drop and weakness of the dorsiflexors, we actually transferred the tibialis posterior tendon. You can see the Mitek suture there, an open anchor suture in the third middle cuneiform to augment dorsiflexion. And we do it through the intraosseous route, a straight direct intraosseous route. We harvest the tib post tendon and then insert it onto the middle cuneiform, and we got a fairly plantigrade foot.
Why did you pick the middle cuneiform?
Because we feel that's the most direct. Whenever we do a tibialis posterior transfer for our foot drop, like we have a lot of experience with from the Paul Brand's time in leprosy. I work in the same center in Vellore. And so we always find that the most direct and straight route through the intraosseous gives us the most force for dorsiflexion compared to the circumtibial route, or you deviate laterally or medially. So we always prefer the middle cuneiform in almost 9 out of 10 cases.
Yeah, I also agree. I like interosseous and coming through the front. I do tend to find if there's zero evert or power, I like to dock it a little more lateral just to try and give the foot a bit more of the up and out posture at rest. But yeah, I agree. I think, your correction looks beautiful. How many casts did you do in between procedures? Do you remember?
Yeah, we have this problem in India that most of our patients come for a short duration, unlike in the West. So we quickly do a cast for 1 or 2 weeks and then get on with it, get the correction done, put him on a cast. He goes back maybe to Bangladesh, which is another country, and then he comes back in 6 weeks' time.
Yep.
So we're limited by a lot of other issues. Yeah.
So I've got some couple of more questions. There's one which is asking, how much do you translate the os calcis when you're doing your minimally invasive procedure? And also, if there is significant varus, do you need to actually remove a wedge to get the heal into valgus or neutral?
Mm-hmm. So I like the rule of thumb for me would be about 1 centimeter. I think if you do more, you put a lot of tension on the medial neurovascular structures. So in that case, if you feel like you still need more, then I agree with you. I would take a bit of a lateral wedge out. And you can do that minimally invasively with the burr too, by just taking a little bit more of the lateral cortices than the medial. It's interesting. I hear from my adult colleagues that they can translate like almost indefinitely when they go MIS. They're quite aggressive with like the tool. I feel like because a lot of the kids that I have are multiply operated or have a condition like clubfoot where we already know their capsules are tight, their soft tissues are just not normal. I don't feel like I can get that much slide, but it may also be that I'm nervous about sticking the tool in the calcaneus and plunging into the apophysis. So I may just not be physically as aggressive as my adult colleagues when I do it. But I feel like getting a good 8 to 12 millimeters is pretty consistent, but I have avoided trying MIS in the kids where I know they've already got incisions in that area, or a very, you know, I don't think I would do it in someone with arthrogryposis, for example. I think I'd risk fracture or other complications. But generally, it's quite good.
And do you prefer to use just one screw or two screws, and any problem with the screw heads? Skin problems?
Mm-hmm. I typically use, I try to use one, but if I don't feel like I'm getting rotational stability or it's unstable, I'm happy to put a second. I am very mindful about where the screw head goes, because I did have one patient who, to date, I've had one patient in my whole practice that wanted it removed. And it was honestly just in a funny situation where she said, if I'm in the bath and I put my leg on the side of the bathtub and my heel touches the bathtub, it hurts, but I want it out, because I guess she bathed that way all the time. I don't know, but I haven't yet, but I think you have to be very careful just about where you end up with that screw head.
You mentioned about this new technique of doing the screw epiphysiodesis on the first ray. Yeah. What are the size of the screw? Because the Pfizer is very small, and
I know. It's one series. I haven't read that paper in a couple months, but I think it was honestly like a 2-3 screw. It was really small. They just used something from, I think, their handset.
Right. Because I think I've used it for the wrist, 1.5 mm screws for the wrist.
Yeah.
Correction is pretty slow. So I think for the foot also, maybe a very, very small screw. There's one.
I've used a staple in the wrist, and like the little Aiken like you would use for an Aiken osteotomy in the toe. I've used those on the distal radius before with good results. So that's potentially another option.
There's another question. So besides X-rays, do you also use a foot score? Any kind of foot score which you recommend for cavus foot?
A foot what?
Score. A foot score.
For functional scoring. He's asking about functional scoring.
No, interesting. So yes and no. I don't use any kind of score that predicts my treatment, other than obviously using, assessing for motor strength and using the typical grading for motor strength. If it is a club foot, then I do tend to do a Pirani score just at my initial assessment, but it's not informing the treatment so much. But I do, as I alluded to, I have registries of my patients with clubfoot and foot and ankle deformities, and I prospectively collect outcome scores. The only validated score in children at the moment is the Oxford foot and ankle score, which is good, but it's not great. So I am using adult scores and some of the PROMIS scores that are not validated at the moment, but I'm hoping that as I get more and more volumes, we can eventually study them to see if they could be used in certain conditions or certain age groups.
There's one more question from Dr. Pushvardhan from Indore. He's asking, is there any procedure for dynamic heel varus in myelomeningocele patients with muscle weakness? So heel varus, dynamic in myelomeningocele patients.
So by definition, to me, if it's dynamic heel varus, it would happen just through swing phase. So that would be akin to the dynamic supination. So I think I would probably still just consider a tib ant transfer. The question then becomes, are you going to do it split or are you going to do it full? I think if you look at the literature, most of which is now very old, tendon transfers like polio, spina bifida were the ones that had the highest risks of overcorrection. So if you're going to transfer anything, I tend to go split unless they already have a rigid deformity where the risk, and they're older, then I think your risk of overcorrection is going to be a lot smaller. But I would be considering either a split tib ant, or if I really thought tib post was a culprit in the deformity, potentially a split tib post, or at least combine a lengthening of tib post with a split tib ant transfer.
Okay, so we'll go to the next. Thomas, you want to ask some question?
Yeah, I think he's talking about a recurrent club foot, which we see very commonly here in India. So
Okay.
we tend to take the whole tib ant and lateralize it, take it above the extensor retinaculum and bring it subcutaneously onto the lateral cuneiform. Maybe. Yeah. For
Absolutely.
dynamic. Yeah.
For a club foot, I would take a whole tib ant, 100%.
Club foot, we'll go to the next case, which Dr. Viraj has got a lot of experience with clubfoot. He sees a whole lot of clubfoot relapses at different stages in his practice. So this is a 6-year-old child with relapsed clubfoot. Viraj, would you like to just take us through your technique? What do you do?
Yeah, actually, this child has a simple neglected clubfoot. So we do get a lot of these children, and they expect a single stage treatment. I mean, because we find them in most of the camps what we conduct in remote tribal areas. So here the main issue is they don't want to come frequently because of the financial reasons and all, and they want just a single stage treatment. So usually for this Dimiglio, I'm talking about 3 and 4 children, the deformity having 3 and 4 grade deformities. For them, we usually do the single stage treatment where we just do the percutaneously, we cut the plantar fascia, and then we do the tendo-Achilles tenotomy, and followed by the dorsal closed edge osteotomy, dorsal lateral closed edge osteotomy, where we do the cuboid, the lateral closed edge. That is what which has been published this in this current orthopedic practice also. So we take the dorsolateral wedge from cuboid and then all the cuneiforms, and then we close the wedge, and then we fix the forefoot to the hindfoot with the help of the 3K wires, and we discharge the patient on 3rd day. We call them after 6 weeks to take out the wires, and then a simple AFO is given to them, the dynamic, and they have been advised to do the squatting at home and walking. So this procedure, what we find is one of the very helpful, because we are not touching the subtalar or the talus, so they do get good range of movement, and the results are really good. For the cases which present like arthropathy, or which are the this is a follow of this child where we did this procedure, and this is a pretty good range of movement. If you see the squatting, so almost good amount of squatting they have, and even they can do the most of the activities, particularly the range of movement at ankle is concerned, because we are not touching the talus, so they do hopping and everything. Those cases like this, in this case, you can see that the squatting, the movement, and even the most of the activities which are possible. And we have good follow-up of these cases. More than now 10 years follow-up. We have many children what we operated around 15, 16 years ago. So they are really doing well without this.
Those are beautiful results. How do the alignment of their subtalar joint and hindfoot looks quite good, and yet you, like you said, you haven't opened the subtalar joint or the ankle joint. Yeah. What do you think it is that's allowing you to regain alignment and movement in the subtalar joint when you're not releasing those? Is it the tib post release? Is it the casting you're doing after?
Yeah, the cast what we keep is for the 6 weeks. If at all those deformities where there is arthroaposis or suppose the deformity is very rigid, in those cases we give the cast after 3 weeks. We repeat the cast after 3 weeks, and they they give the good amount of correction. Particularly for the arthroapotic children, like we have a couple of cases where they have been operated thrice or maybe 4 times or 5 times in the past. We find that some amount of the subtalar release is required, as well as we may have to raise the ankle capsule also. So we just increase the incision, what incision we do the tenotomy. So we just increase the incision for say 1 or 2 centimeter, and from that same incision we do the subtalar as well as the posterior ankle capsule release. That is requiring arthroapotic cases. This procedure, what we were like you have shown the cases, couple of cases where we get a lot of cases of meningomyelocele, like Rujita even also asked, and where these children they get a lot of ulcers and osteomyelitis even the midfoot bones. So this procedure is helpful to these children also, because while doing the osteotomy we take out the dead bone or the osteomyelitic bone which is there, we take out in the same stage, and we do have good amount of follow-up of those cases having the meningomyelocele, and many of them are really doing well with this procedure, because the correction is at bony level, then, because as you said that there are high chances of recurrences if you try to do the multiple the tendon transfers and all. So only thing is they have to, yeah.
What's the age range of the patients you've done this combination?
Usually, I mean, we don't do below 5 years of the age group. After 5 years, we do this because of maybe of arrest of, I mean, the growth arrest and all. So usually we do this procedure after 5 years of the age group. And the last age group what we operated is one of the lady we operated. She was 45-year-old. She had in the childhood she had this problem.
Raj, I've got a question coming. Sorry to interrupt you.
Yeah, please.
There's a question from Saudi Arabia,
Yeah.
Dr. Ali.
Yeah.
He's asking, what do you do with the acetabular dysplasia in patient with CMT? And do you believe that the dysplasia is painful in children with CMT? This question is for Mary's.
Okay. I was gonna say.
CMT expert.
You're the expert in CMT. We very rarely see CMT here.
To be honest, the patient that I showed you in my cases, he's the first one that I've found. So we don't know a lot about it. We don't know when it develops. Is it when they're 10? Is it when they're 16? Is it when they're 4? We don't know. And typically I would say it's not painful, but I don't know about the adults. They would never present to my practice. So I'm not sure if when they're 30 or 40, they start to have pain, but certainly in children, I don't think so. And then that begs the question of, I see them when I meet them, I do the x-ray, but if it's negative when they're 12, am I supposed to repeat it when they're 14, 18, ever? We don't know. And I would admit to you that I don't tend to repeat it, but most of the kids I see are already in adolescence. And I think if they're going to develop it, they'll have it by then. But I don't have proof. I don't think anyone does. So I think a PAO is probably going to be the answer for these kids. But again, I think it's quite rare to find it. But I think the one, I don't know what the number needed to treat would be, but to me, especially with the advent of x-ray machines like EOS, just get one x-ray, try and rule it out. And for that one kid that I've found in 5.5 years, to me, that's worth it.
Thomas, you want to ask?
Yeah, it's just interesting that we don't see many CMT here in India, thankfully. And so our pelvis X-ray is actually not part of our workup. We do an MR spine, do a ped neurology consult. If it's a neurological case like a spinal muscular atrophy or a denervation neuropathy, we hardly see any Charcot-Marie tooth. So it's, I think in the Western world and even in the Gulf where I worked a year, there's a lot of consanguineous marriage, and I saw a lot of CMT foot in that part of the world. for some reason, we don't see that many in India. So we rarely take a pelvis with both hips X-ray to look for established dysplasia in our population. We do just a
Thomas.
neurological workup, do an MR spine or lumbosacral spine, and then do a foot AP standing lateral, weight bearing views, do the Coleman block, and then decide on the algorithm like you said.
That is, you worked in Uganda. I believe you were in Uganda for some time. Did you see
and
clubfoot what Dr. Viraj is saying? Some of the rigid deformities there?
yeah, actually in Uganda, I was there mostly doing research, but I also did some clinical work. And I would say most of the pediatrics, thankfully, they have a well-funded pediatrics hospital, and it is like in combination private. So I didn't spend a lot of time there, and most of the kids end up there. Interestingly, I've followed up a few of their club feet in Canada and the US since, but they do a great job. But and also there were people there like Norgrove Penny and Shafiq Pirani who did a great job teaching Ponseti around the country and treating feet. So I think as far as there's always tons of neglected club feet, but Uganda is not so bad compared to others. Where I've worked most recently and treated more feet like the ones you've just shown is in Vietnam. I'm part of an organization, and I've been going to Vietnam every year or more for the last 3 years, and certainly that's where I've treated neglected club feet. But shockingly, in Toronto, I've had a lot of residual neglected severe club feet where I've done these multi-stage approaches, probably more of them there than I have in Vietnam. I like this concept of the dorsal lateral wedge resection. I certainly would consider that in the future. I've done more Lambernoudi triples in these cases, which the results are okay, but I don't think they're great. So if there's a better option, I'm very interested to look into that.
I have a question for Viraj.
Sorry, Thomas.
Yeah.
Sorry, Thomas.
So, like Marie said about the hind foot, I'm just asking Viraj whether he eyeballs the deformity, doesn't calculate the apex where it meets on the dorsolateral side, or does he just eyeball it and take off a big wedge? How does he go about taking that wedge?
Yeah, it is always see if the child is walking on the lateral aspect of the foot or the lateral border of foot, approximately around a centimeter of wedge is usually sufficient. But if the child is walking like a reverse foot, what I mean, the case what you have shown, suppose it have been a recurrent case or maybe very rigid neglected club foot deformity. In those cases, I would go and take out more wedge. Sometimes if it require, I will go and even I take the navicular into the osteotomy. And very rarely, like orthorhaptic feet, one of the few cases we have from Nigeria and all the countries. I found that orthorhaptic cases, those cases are much more challenging as compared to what we find in India. So those are the children where I have to take out even the basis of the metatarsal as well. So I think it varies from case to case, but usually 1 centimeter wedge is much more than sufficient for the cases what we are getting in India.
And do you get a lot of skin problems? Okay, sorry.
Thomas, we go to the next case. This is your case.
Sure.
12-year-old child. You want to just go through this case, Thomas?
Yeah. Actually, that picture of the previous one was actually the clinical picture of this. So this was a more rigid variety, 12-year-old chap with neurological, I think it was spinal muscular atrophy with weakness of the plantar flexors and peronei with a fairly rigid equino-cavovarus foot. And you can see the amount of the talo first metatarsal, the Muir's angle in the calcaneal pitch, and the calcaneo first metatarsal angle, which is fairly huge. And he actually came just walking on the forefoot.
Right.
So fairly rigid, older child. So we actually did a first stage soft tissue release, did a Steinlein, put an Ilizarov, and unlike what Marie said, we don't do an osteotomy. We rely here plainly by doing soft tissue distraction. But in this case, we had to do a midfoot osteotomy to get the forefoot back and fix it with some staples and K-wires. And then we progressively, gradually distracted the hind foot with Elizarov ring over 3 to 4 weeks and got a correction like that. So in an older child, above 11 or 12, at one point I was doing a lot of Elizarov here for even below 8. But now of the last 5 to 5 years, we slowly moved for Elizarov for the more rigid, more than 10, 12 years of or recurrent deformities of the skin is bad. We reserve Elizarov for such cases.
Mary's, how would you approach this case? Okay.
Yeah, I was thinking the same thing, that I think the amount of midfoot cavus is so severe that you'd have to take out so much bone to do something acutely. Sorry, even if you did some acute soft tissue release and cast, I just don't think you're going to get enough, nor would you be able to really fit a cast on this leg. I missed if he had motor function or not, but assuming he probably doesn't have much, I think an Elizarov is really the way to go here. I don't know.
We had to do a lot of soft tissue correction. We had to do a long tender Achilles lengthening, a substantial open Steindler, do a huge midfoot osteotomy, and then put the frame on for the residual hindfoot equinus to gradually distract it over 3 weeks to get a plantigrade foot.
Did you do any correction of the cavus through the frame, or only use the frame for the equinus?
Yeah, so most of the cavus we got by doing the midfoot osteotomy and the Steindler. So most of our distraction was for the hindfoot equinus.
Almost suppose you don't have expertise with the frame.
Yeah.
Or what's the other option? Can you do serial casting and then go ahead?
No, I think for these rigid ones over 12 years of old age, it probably helps to a certain degree, but if it's fixed, if the child's been walking on it for a fairly long period and the foot is rigid, I don't think casting makes much of a difference in these cases. But like Marie said, if you do osteotomies, you shorten the feet. You do a lot of osteotomy, you tend to shorten the feet. You have to be careful of skin problems and vascular problems. So I tend to use Elizarov in the rigid ones, fairly rigid ones over 12 years after doing initial soft tissue and bony correction and the limited bony correction.
Mary, do you have experience with the Taylor's facial frame for these deformities? Are you doing a lot of frames for these?
So it's interesting. Exactly as you were saying, I feel like the use of the frame is maybe I'm a little less liberal with it than maybe when I was training 5-6 years ago. I felt like in a 6-month period in Melbourne, we put on maybe like 6 or 7 foot frames. But I feel like with the staging of soft tissue releases, a cast, and subsequent procedures, I think you can avoid a lot of cases that otherwise might be considered for a frame. So I have a lot of experience with TSF, but to be honest, I'm not putting them on feet that often. I've done 2 in the last year, one more Ponce Taylor type frame of a rigid small club foot that just wasn't improving with casting at all. I did her complete soft tissue distraction at age 7. And I did the case that I showed you, but I haven't had to do a lot of foot frames, and I'm okay with that. I think foot frames compared to other parts of the body are not as well tolerated. The beauty of a soft tissue only one is you can stop and go, without worrying about premature consolidation. But I find them a little more uncomfortable than the average frame, for sure.
Right. There's a question which, are there any fixation problems with CMT bone?
I haven't had any. To me, the ones that are the hardest are the club feet that have been either not walked on or walked on the lateral border of the dorsum. I feel like the bone's exceptionally osteopenic. So when you go to do your osteotomies, whether it's the calcaneus, the midfoot, the bone is so soft. So those are kids where I might consider at least wires and sometimes like a small plate, because I'm worried that the osteopenic bone will collapse again, but not in CMT.
And there's another question. Have you used any of the commercial foot system by Arthrex? They have a system for triple arthrodesis. Have you ever used it, or have you ever seen it in a practice?
No, I haven't used theirs. To be honest, I think most foot and ankle surgery you can get by with screws and K-wires and then the occasional plate. There's definitely some use. I mean, I've helped develop some implants too, and there's certain little instruments that can help you be more precise about, you know, your osteotomies, and that'll make things easier. Actually, I like staples a lot, and I think the advent of the memory staples with nitinol, I think that's lovely. The self-compressing staples, that's probably my favorite commercial tool, but I haven't used anything more fancy than that.
So more of a logic, Atul, rather than implants, right?
Let's go to the next case. This is a 15-year-old girl. I'll just go through this very quickly. Choose what Viraj has already discussed. We get these rigid club feet like these, and we child walking on the lateral border of the foot like this. What would you consider at 15 years, Mary's?
What would I consider at 15 years, like at her age?
Yeah.
Yeah, I mean, she's, you know, to be honest, it really depends, I think, also on the setting. So where does she live? How often can she come to the hospital? And if I really had only one chance to operate on her foot and I was never going to see her again, then this is where I think, like I said, I love this option of the dorsolateral wedge resection with the soft tissue releases, or in this case, a Lambernuti triple. If I had her in my own clinic and I could see her as often as I wanted, then perhaps some stage releases with casting, and then a more aggressive resection. I would still tend to stay away from a frame, probably. This foot's really small. It needs so much correction. And especially when it's bilateral, I don't like subjecting kids to frames twice. But yeah, looking at the skin flap here, I mean, we haven't discussed that, but skin management is always such a challenge. And I haven't used flaps, and I haven't let wounds close by secondary intention before. I think because I've tended to use the Lambernuti triple, I haven't had major issues with skin, but I have done some serial cast post-op, so a slightly suboptimal correction, and then stretch out the skin once it starts to heal. But I'd love to know your preferred approach for skin management in these cases.
Interestingly, what we did was we used the same skin on the walking. We had the plastic surgeon who came in, and then he kind of used the skin as a graft. And we kept the foot in equinus so that let the soft tissues heal. And then we did serial plasters every 2 weeks, and soft tissues healing down. We don't expect much movement anyway in these feet.
Yeah.
We get this foot into a shoe or a sandal, which they're comfortable wearing it, and that's what he got at around 3 years. That's the follow-up. I think this is Viraj's case where he does them bilaterally. Again, you know, a lot of these cases come in our setting. Maybe you can visit Viraj in Nagpur.
Be great.
Instead of Vietnam.
I actually have one. I don't know how many cases we have. I have one that I would love to show you because I've done one side, and I would love to know your opinion for the second side. But I'd be happy to. I don't know how many we have, but I was just hoping.
Do you want to show that now?
Sure.
Okay, well, let me stop sharing this.
The only thing, can I just interject there, Atul?
Sorry, yes,
whether for that case, whether Maris will consider a triple arthrodesis. I know she worked with Professor Mosca, who actually doesn't like the triple. He tends to say that if you make the subtalar fused, you develop ankle arthritis. So, but in a girl who's over 12 or 13 and we want to do a single stage correction, probably triple is an option. Triple arthrodesis is an option.
Yeah, that's a good choice.
Go ahead.
Oh, sorry, you can go ahead, please.
No, I was just going to say, I mean, if you look at the literature for long-standing results of triples, there's not much, but almost everyone has ankle OA. It's true, but most of the authors will conclude that they didn't feel that it impacted negatively their patient-reported outcomes. As far as I could find, there's one series of 10 patients who had Lambernuti triples, mostly for polio, at 37 years, and they all had adjacent joint arthritis, but nobody went on to have an ankle fusion. So I think you have to balance, especially in these patients, they have such horrible feet to start that just getting them plantigrade and shoeable, we can't fix everything, I think, in my opinion. So this is a girl who presented to my clinic. She's had all of her care in Canada. She's not from somewhere else. She has arthrogryposis. Her hips were well managed, but her feet were kind of neglected. She had some Ponseti treatment in Achilles tenotomies as a baby, and she just recurred so severely, wasn't braced, and here she is at age 11. When I first looked at her, I didn't really know what to do. And I have to admit, I didn't know all the amazing work you guys were doing, and instinctively opted for the approach that of, soft tissue releases, casting, and finish up. So I started with what I thought was the least severe foot, which was the right. I took her to the OR, did a plantar medial release and Achilles tenotomy. In her case, I just cut all the tendons because she's arthrogryposis. And then I serially casted her. After 7 casts, we had the right foot like this, as you see here. And then I did 2 more and took her to the OR, where I did a plantar medial opening wedge. And here I used that plate because she was so osteopenic. We have her above plantigrade with a nicely aligned foot. And I still have the second side to do, but I feel like this left side has that even worse midfoot deformity and equinus. And so should I be trying the same thing? Should I be considering now maybe this dorsal lateral wedge resection? What would you guys do for this side?
So in my hands, in arthrogryposis, I'll have no hesitation in putting a frame. After doing the initial soft tissue, like I said, the Steindler and the TA lengthening, I'd probably put a frame in a child who's over 11, fairly rigid equinus like this. But like you said, your results are very good on the other feet with just staged procedures. So, but I don't know, we don't have the luxury here of doing staged and following up. Some patients don't come back for follow-up, and most of our patients are poor. They don't have state sponsorship, like health insurance is not an insurance, and out-of-pocket expenditure is a concern. So we are actually handicapped with a lot of other considerations as well.
Viraj, what do you?
As I said that, this is a child where, no doubt the surgery what you have performed is excellent and given the good result. But in my hand or in our setup, we do get a lot of these cases. And
Viraj, can you speak up? Yes, speak
yeah.
up.
Speak too closer to the
Am I audible? Hello?
Yeah, now it's okay.
Yeah. So in our setup, we are really happy with the dorsolateral wedge osteotomy, what I was talking about, along with the soft tissue releases. In fact, these are the cases where we have to combine the soft tissue release, and I wouldn't be, happy to give the proper incision for the medial release, right? So what we do is just we extend the incision what we take for the tendo-Achilles stenotomy. We just extend that, and from that incision, maybe 2 centimeter or 3 centimeter incision, we do all the soft tissue releases, right? So that we are not getting the wound problems, as one of the cases even Atul has shown just now, right? So that is there. And secondly, these are the cases where we may not be able to get the correction with simple midfoot, right? Like cuboid or medial cuneiform. We might be able to go even up to the basis of the metatarsals as well. But I think with this, we can get a good amount of correction if you try with the wedge correction. And secondly, it is possible that you might need one more cast, maybe after 3 weeks or like something. So rather than waiting directly and taking out the wires after 6 weeks, these are the cases where we may need to take out the wires at 3 weeks, and we may need to give some correction for the soft tissues at 3 weeks. So, but I think still we can get a very good correction with the dorsolateral wedge. I will still go for that.
There's a question, Mary's. Do you have any experience with telectomies? Have you ever seen them or performed telectomies for neurogenic foot?
Yeah, I've done a couple in young children. I've never done any in older. Yes, in the younger kids, arthrogrypotic, like Freeman, Sheldon, really rigid. I think it can work, and these kids seem okay, but their demands physically, are just going to be lower because their hips aren't great and their knees aren't great. And probably their spine and respiratory reserve aren't great. So, but I've not done it in an otherwise like healthy idiopathic clubfoot. I would love to know if you guys have that experience.
Atul, the biggest problem with the talectomy is a forefoot adduction is very difficult to correct. It still remains, you know. You
Right.
remember one of the cases what we operated in POSI this year, you know, where they try to take out the talus, you know. So it
The
is very
salvage
difficult.
procedure, I mean, it's mainly for salvage, so I don't
Yeah,
think we
yes,
use it
yes.
very routinely.
Yeah.
Mary's, it's coming to an end. It's been a real pleasure. It's been 1.5 hours of great discussion, and it's been wonderful to have you. And if you have any questions, I'm sure we can mail it to you.
Yep, definitely.
At the Salter Society meeting in October, one of us will drop in there.
That would be great.
I'll tell Dr. Dhiren, who's our president, to just give some concluding remarks. Dr. Dhiren, are you on the?
Yes. Thank you, Maurice and the panelists for a wonderful interaction. And it was a great learning experience for all of us. Before we end, I would like to announce about our further webinar. On this Saturday, we have a webinar on Blount's disease. And the expert we have is Sanjeev Sabharwal. And another important webinar, which is going to be on Sunday. And that webinar is, the expert is Dror Pele. So he will be speaking on super hip and super knee procedures. I will mail you and circulate the details about that. But once again, I thank everyone, especially the Maries, for our time and sharing their experience, and the Indian experts for sharing their work with Maries. So thank you very much once again for joining with us. Thank you.
Thank you, Dhiren bhai.
Thank you.
Thank you,
So much
Atul.
for having
Thank you,
me.
Mary.
Thank you.
Thank you. Bye-bye.
Thank you so much. Bye.
So good night to everyone from India and good morning to you.
Yeah.
Thank you.
Bye-bye.
Take care.
Thank you very much.
Bye.
Thanks.